Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is CMIO's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. C.T. Lin. Dr. Lin is CMIO at UCHealth, a 12-hospital, 900-clinic system in the Rocky Mountain region. UCHealth has achieved HIMSS Stage 7 and CHIME's Most Wired Level 10. Dr. Lin is a professor of medicine at the University of Colorado and board certified in internal medicine and clinical informatics. He sees internal medicine patients and also facilitates workshops on excellence in communication to reduce burnout and improve outcomes. His national publications and talks include Addressing Physician Burnout with EHR Sprints and Online Patient Communication with Open Test Results and Open Notes. His national awards include Healthcare IT Innovator and Electronic Physician of the Year. He leads a team of 25 physician informaticians and follows the mission to improve physician and team resilience and effectiveness by building extraordinary relationships and innovative tools. Dr. Lin, CT, welcome to the show.
Thank you.
It is absolutely amazing to have you on. You are famous in the IT world, in the health tech world, for your epic-themed ukulele parodies. And I actually saw, I think it was 10 years ago, you graced the health tech community with Epic Man, your Rocket Man Elton John parody at the 2012 UGM. And I was curious, was that your official debut into the world of parody, or had you been writing and playing parody before?
That was my official debut. In fact, I'll tell a story that my daughter, who at the time was either 11 or 12, she was in her tweens, and she's embarrassed for everybody, especially being the daughter of a guy who was trying to learn and play ukulele at the same time, much less play parodies. We had been in Hawaii, and I discovered a tiny guitar in one of the closets in one of the condos there, and I'd never heard of a ukulele before. And so this was about a year prior to our epic go live in 2011. And one evening, as I was sort of playing the instrument, we heard Elton John's song come on, and at the time we were designing epic pre-flights to get doctors ready, their checklist of the things that you need, the macros and all the things, personalizations you need to set up before you go live. And this comes from the sort of pilot pre-flight checklists. And Elton John comes on and he sings, "She checked my bags last night, pre-flight." And I thought, that's the song I have to write. In fact, my wife chimes in, she says, and you need to call it Epic Man. And I'm like, wow, okay. And so that's how that was born. The day I decided to take this to work, my daughter sits at the breakfast table and she says, "Dad, you're not going to take that to work." I'm like, well, yeah, I'm going to sing a song. You're not going to sing it at work in front of people. You know you can't sing. You're terrible at that. I'm like, oh. And the introvert in me almost, sort of put it down and said, yeah, she's right. Well, what was I thinking? So it almost didn't start before it started, but I was glad that I did. I played this for our command center of 50 red shirts, right? And so if you imagine on a Friday at the end of Go Live, 50 red shirts have taken 7,000 trouble tickets from the physicians who we've moved everyone's cheese. Where's my prescription pad? What's my login again? Why do I have to log in? Because I could easily give a verbal order. All of these sorts of things. And so these folks were sort of beaten down after having 7,000 complaints logged that week. And so I played my song for them and have never really looked back.
That's amazing.
So how many songs have you written over the years, do you think?
I think I'm up to like 23. Most of them are on my YouTube channel. So
amazing. We'll have to link to that at the end as well.
Well, most definitely, yeah, we will. Well, let's transition to something a little bit more in the realm of health AT. I've read, actually, you found your job at UCH by accident, and I was wondering if you could elaborate on that.
Yeah, I like to say that I was a sensitive man of the 90s. My wife is pulmonary critical care, and she had graduated fellowship and had matched her job at University of Colorado. And I was very happy as an assistant professor at UC Davis in California. And at the time, in 1995, no one was hiring for an internist in Denver. I'd gone to all of the major hospitals, the university wasn't hiring, and so forth. And it wasn't until, nearly just before we moved that I'd connected with a colleague of a colleague of a colleague who knew somebody, and sort of an accidental sort of, we could probably slot you in here at the university. So I haven't looked back. I've been here now 28 years. But boy, when I landed, I was sort of going to be a house husband to start with.
Yeah. Oh, wow. That's amazing. So now, since joining, you've experienced so much change over the time. You've, I think, migrated EHRs 2 times, possibly more, and you've implemented new technologies, new workflows, you've trained new teams and new processes, obviously impacted countless patient lives, both with your internal medicine practice, but then also with all of the EHR work. Out of all of the technological change that's happened over the years, what's been the most impactful holistically?
I'd have to say it's information transparency, the ability to share information that was otherwise locked in paper charts, right? I used to say our medical information used to travel at the speed of the courier in traffic on Colfax Boulevard. And that meant that if you requested a chart from the main medical records, and we had 12, 16 buildings located around Metro Denver, and it would be either a stat pull of a medical record would be easily half an hour for someone to drive to you, or routine would be tomorrow, maybe the next day was when you get your paper charts. I remember the days when I practiced internal medicine, and the only thing I would have on the patient would be patient's vital signs written by my MA that morning, and patient states no known allergies. Here you go. Here's the record. And the patient would sit down and say, so I saw the pulmonologist that you referred me to last week. What did he say to you? Because he said he was going to send you a summary of his findings. And I go, what do you remember that he said to you? And I'd be like, really? You have nothing? I'm like, I have nothing. Right now. Oh, actually, don't worry. We created a shadow chart, right? We were writing on non-carbon paper. So we would send one copy to medical records. And since we didn't trust medical records to come in time, we would keep our own copy. Well, sure. So we set up another set of medical records on site, and even that copy would be on some biller's desk or some front desk person receiving a phone call, and you still can't find your second copy. So here we are with paper on top of paper, and still about 30 to 50% of the time, no paper at the time that the patient shows up. For us to be beyond that and say, it doesn't matter, I'll log in, and any computer system I sit down at, I can pull that up. That's beneficial. The other thing the patients would often say is, oh, my husband, Frank, he needs a refill of his blood pressure med. I don't know what it's called. Mary, can you pull Frank's chart? Mary's busy. I don't know. Hey, how about tomorrow when I pull it, I'll give you a call. I mean, it's just super inefficient. No charge for today's visit because I had nothing on you today. I'll just make a call tomorrow, and I'll just write off your appointment. Really? I drove over here for an hour and parked and all this, and you have nothing? I have nothing. So A, information availability, and B, information transparency. We couldn't possibly, right, in the past say, let me photocopy your chart and send it to you every day so that you keep up with what we're writing in your chart. That's just not possible. But for now, for us to be able to say, you know what, at the same time I sign this record for myself, we'll send you a copy. You'll have a copy available to you. All your test results, all your doctor's notes. That's been transformative.
Wow.
This is a great segue, I think, to, you've been a big proponent as well of transparency with patients around open notes and sharing kind of the medical record with patients more transparently. And you've been, I think, one of the pioneers of it. Love to maybe share a bit more about your story overcoming the obstacles with open notes. And then I'm also curious, like, how widely are you seeing that being done today?
So we started with a project we called SPARO. In fact, SPARO, our acronym SPARO, is so poorly spelled that if you Google it today, I think you'll actually get our original report. It's SPPARO, standing for System Providing Patients Access to Records Online. That was coined by my colleague Steve Ross, who was my co-author on a paper we wrote back in we did the study in 2001, published it in 2003. And what we did at the time was on our original 3M clinical workstation lifetime data repository, right? When we invested in our first EHR, it was 3M. We would publish that to the patient on a homegrown portal. And we showed everything back then. Progress notes, test results, echocardiograms, biopsies, all in real time. And we were able to demonstrate that, no, the walls don't come crashing down. Patients don't call and sue us for calling them smelly. And, all these things that we used to say in the medical record that we've sort of changed over the years. We published that in a randomized controlled trial and showed that not only did patients trust us more because we were so transparent with them, but that they had a better loyalty and didn't transition to other practices as much because they felt like no one else offers this level of transparency. And then the fear that our physicians and nurses had about the deluge of phone calls, about the slightly abnormal results, did not occur. We actually studied it, and the study actually ended up paying for 4 hours of a nurse's time per week for the anticipated deluge of questions. And we asked them in exchange, please keep a logbook of all how much time you're spending dealing with test results and questions related to the record. And it was 5 minutes a week. 5 minutes a week in total across all 100 patients in the study. And you can imagine that scales to, yes, it's not zero work, but and most of that 5 minutes of additional work happens in the first 6 months as patients call and say, hey, what's my TSH result for my thyroid? And you're like, actually, it takes 3 days for the TSH to come back. We're not withholding it from you. We don't even see it yet. We're like, oh, sorry to bother you. So patients understanding what the timing of release looks like, and then all of those questions really evaporated. And then the trust level really increased, and the satisfaction did as well. And so that's early stuff back in 2003. To your point about so we showed that there were significant p-value differences between the experimental group and the control group. The trouble is, back then, myself as a leader, I was a better scientist than I was leader, because I thought that, well, I'll just show everyone all these p-values. It's amazing. People will obviously instantly change their minds if I show them p-values. It's about the data, isn't it? We're all scientists at heart. And the answer is, actually, it's not true. No one showed me this book, Leading Change by John Cotter, until about a decade later. And is it any wonder that during that first decade, so many of my projects just flopped and failed, including this one? In fact, the practice that we went live with in cardiology, at the end of the project said, good, project's over, right? Your research study, let's turn it off. And we're like, well, your patients love it, though. Yeah, whatever. It's just a lot more work for us. Well, no, we showed it's not more work for you or your nurses. Yeah, just turn it off. We actually went back to the research patients and said, your doctor's about to ask us to turn this project off. Would you like it to continue? And there was a spontaneous email campaign. Almost everyone wrote in and says, please keep it on. This is the most valuable thing you've ever done. And the doctors were like, fine. It's not more work for us. So yeah, to realize that you could publish these studies and have these great findings, and yet even the folks involved in it were like, what's the big deal? I don't get it. And then when I tried to pass this on to the other 39 practice directors, hey, we just studied these patients in cardiology and they were very appreciative, and the loyalty goes up and the trust factor goes up. Don't you want that for your practice? And the answer is no, not really. Clearly, cardiology patients are simpler than my patients, because my patients are so nitpicky. They will clearly have the problems that those you didn't find it there, but clearly my patients will. So we're not interested. And I didn't understand that it's about changing behavior, changing minds behind the scenes, that I didn't do the homework for, to set your guiding principles, create your guiding coalition, make sure your leaders are lined up behind you, celebrate your early wins. Most of those things I didn't understand how to do. And it wasn't until years later that we were able to make this like system-wide. So we were able to adopt this before the information blocking rules. We did this back in 2016 and we're successful. But it's harder work than you think, right? It's not publishing a paper and going, look, well, read the white paper, we're ready to go.
I think such a fascinating and important lesson, CT, that, in some ways the technology is like the easy part, but the change management, to your point, is the hard part. And it's almost like you have to help others agree that there's a problem to be solved that we are all aligned on. Otherwise, they don't care about the solution. Right. And I'm guessing you've probably seen this play out with other, health IT and digital initiatives. And so now, like, the change management lessons you've had, have really changed how you approach adoption of new initiatives in IT.
Absolutely. Fundamentally, these are the things. So I in my first decade and a half, I was the entire medical informatics department at my organization, right? Notwithstanding the fact that I was medical director of informatics, which is boss of me. And then later I was senior medical director of informatics, which was boss of me. And then it wasn't until 2011 with our Epic Go Live that we realized, we really needed to ramp up our industrial strength informatics program. And now I've grown this over time to 23 physicians who are part-time physicians and APPs who are part-time clinicians and then part-time informaticists under me. And then we're able to sort of emphasize change management in our deployment of IT tools, right? It's mostly change management. And by the way, we also have tools. The mission statement you said for us really speaks to that, right? The way we go about things is that we develop outstanding relationships. And oh, by the way, we have innovative tools. Right. And it's the relationships that drive things forward.
Right. I'm curious, CT, this is a random question, but with how much, clinical documentation burden there is now for physicians, are you finding that a culture and organization where IT is like stronger, streamlined, better is a way to recruit physicians nowadays, or are physicians not at all really looking into IT when they're deciding where to work?
I think I would be overstating it if people say that they come to UCHealth because the IT program is so strong. Sure, I would love to as my daughter would say, don't hurt your elbow patting yourself on the back so much. No, so I don't think so. But I think that people will, once they arrive, they'll say, well, gee, this Epic isn't at all like the other Epic I was using. And I think it has a lot to do with how strong your informatics program is at dedicating itself to streamlining workload for clinicians.
So maybe not a reason to come, but maybe a reason to stay.
Yeah, right.
I love that.
Actually, I will say there are physicians who say, I moved away and then I decided I miss how we did it back home, and it could be one of the factors for people coming back to us.
Yeah, that's fantastic. I made a mental note when I read through that mission statement. The fact that you have extraordinary relationships before the innovative tools, I think that speaks a lot to your mindset and what you've learned over the years. One statistic, I've actually heard you speak this before, is that 80% of improving the EHR really comes down to training the end user and 20% is technical improvement. And to support this, you've recently implemented what's called the Sprint program at UC. Could you tell us a little bit more about what is the Sprint program and how does it work?
Yeah, so I think if you Google or search on PubMed, we've written a couple of papers on our EHR optimization sprints. I will fully acknowledge that David Butler, when he was at Sutter, came up with a program he called Integrated Architects. And when I saw his talk at Epic, I think it was 2013, 2014, I brought the idea home. It took me 2.5, almost 3 years to get a program like that funded. But the vision is this. If you take smart people pulled from different disciplines within the IT shop and have them led by a physician informaticist who understands clinical practice, you can take an EHR that is sort of out of the box vanilla and not very well accepted, from not very helpful for clinical practice to really sort of outstanding in a 2-week period. And so that was the idea, is well, our current team is about 11 people, but at the time it was 6 or 7 people who we could steal from their existing day job to immerse themselves in one practice and see what you could do. And part of it was that the reason that people want to accept you into the practice is, oh, good, now you can come in and fix all of the problems in my endocrine practice with the EHR. All these buttons are wrong. You need to refix that. And in fact, people will say, oh, what I'll do is I'll take vacation for the 2 weeks you're here. When I come back, it'll be all fixed, right? And we're like, oh, this is such a misunderstanding. And what happens is that even though people expect that it will be technological change that makes us better, almost none of that is true. We will fix a couple of flow sheets. We'll build some specific diabetes things that are specific to the disease processes that you work on. But 80% of the improvement is watching people do their work. They do these 17 clicks, and then you say, well, try that one button. They're like, what? That did all those 17 things in one move? I'm like, yes. How long have we had one of those buttons? Well, since the beginning, but you didn't know to push that button, and you didn't know what that did. So a lot of it is, when we put people through in the beginning, our 6 to 8 hours of training, you're zoned out after the first half hour. You're really not incorporating the rest of that specialty knowledge. And then we, in the first decade of our deployment, really didn't go back and say, do you have any questions? Can we optimize your workflow? And the sprint was the first time we really did that in a serious way. Not only optimizing for individuals, here's all the quick actions you can build for the tasks you have to do. Our big mistake during sprint, our first sprint, was that our medical assistants and nurses, their burnout worsened as a result of the sprint, because their perception was, well, when sprint comes to town, doctors can spray messages at us way faster than they did before. And so you're just shifting the work. And so unless you go after teamwork, hey, you know what? This is not an in-basket ping pong game. Why don't you huddle for 5 minutes and knock out 2/3 of your in-basket just by talking? Oh, I can take care of this one. Oh, you know what? I'm going to delete these 3. That's not a problem. Oh, can you please spend a lot of time on this one? Oh, I wouldn't have gotten that by typing back and forth, back and forth, back and forth. Just spending time outside of the EHR the teamwork there, collaboration there, sometimes just makes a lot of the tasks go away. And so these are things that people don't get out of the box. They go, well, gee, I have 57 messages. Let me just sit down and knock them all out. Whereas, half of the messages are going to the person sitting next to me. And like, could you just have leaned over and talked to them? Oh, that's a good idea. Never thought. So sometimes it's thinking outside the box because people get so focused on what's the next task in front of the screen in front of me. And we feel like that's worked very well for us.
Can I ask you, so change management across such a large organization is very difficult. And I guess often you need champions at all levels to move things forward. Do you strategically work to identify a champion in let's say every single department? Like you have a list of okay, this is I don't know, the orthopedic champion, this is the cardiology champion for us. Is that how it works in large health systems?
I think everyone does it slightly differently. Cultures in every organization are different. One of my colleagues said to me, the academic health center is perhaps the most socially complex organism on the face of the earth, partly because the School of Medicine is different from the billing arm is different from the health system, and they're all led by different leaders with sort of overlapping but not exactly aligned motivation. And so changing things in an organization that has, people pulling in different directions can be quite challenging. For us, what we've ended up doing is hiring folks that we've found clinically effective leaders, and then asking them if they would be interested in participating with the informatics team, because informatics is where we make lots of change and lots of clinical processes. And so we probably represent 2/3 of the specialties on my informatics team of 23, but there are a number of specialties that are not explicitly represented. And we would rather pull people who are effective leaders first and train them on informatics, because it's not necessarily true that the junior faculty guy who, quote, grew up as a programmer, let's have that guy on the team, but is not clinically respected, you get not nearly as far in terms of changing things with that sort of person. Now, you need some folks like that to do some of the work, and so you will end up with a balance of folks who are sort of programmer heritage, but clinical leaders who then develop an expertise in informatics. That's the sweet spot for folks that do well.
Right. Makes a lot of sense. Suchi, one thing I noticed in all of your epic parody videos, but then all the lectures you've given online, you really come across, it seems to me like very happy. And honestly, it's 100% my genuine opinion on that. And I know that physician burnout right now is such a hot button topic, and pajama time is, always being discussed, and we're spending so much time in the EHR doing documentation, handling messages like you suggested, 57 in-basket messages. How are you working at the organization to help tackle some of these issues?
That's the whole job, right? Sometimes I walk into meetings now and I introduce myself as CT Lin, CMIO. I'm the guy who ruined healthcare. And people say that, sort of grumble that under their breath. Oh, CT's here. He's the guy who's forcing us to type in the damn computer. And we're like, no, guys, be careful. What we're trying to do is we're trying to transform healthcare. We are going through this change cycle of when we implement a new tool. And I would say, in the history of centuries of medical tradition, the EHR is just a flash in the pan. This has only been, a decade or so that we've been serious about trying to electronify workflow and basically ripping out all of the, decades of, paternalism and all these things that we have sort of baked into our culture that we've learned, and unlearning them. And as a result, clinicians end up feeling like they're newbies, right? Gee, I used to be a 15-year, 20-year veteran of neuroscience, and now I look like a newbie sitting in front of my patient where I can't navigate the keyboard or the mouse, and I can't find the thing I'm trying to find to take care of you. And so no one likes that. And coming through and thinking about how to build electronic workflow into folks who are clinically expert, it is a huge disconnect and a challenge if you don't do it right. And to this day, we're still struggling. Our EHR version 17, we think we have dozens of versions to go to get anywhere close to getting it right, and having it sort of disappear into the wall. The future vision of Star Trek where, Captain, give me warp 10, and you talk to the computer and it's your instant invisible assistant, that we would love to get to that point. And I think there are some nascent technologies with Dragon and ambient listening and so forth that are trying to move in that direction, but we have a long way to go. The burnout piece is not just the EHR. As you've read the research articles, part of it is chaotic practice. Part of it is the clinical burden is too large. Part of it is, of course, with pandemic, understaffing, right? Some of our specialties, you can't get in to see them for 3 to 4 to 5 months because there's just no one there to handle the volume of incoming requests. So we're struggling through all of that, and all we can do is incrementally knock down the workload. Can we make that a little bit simpler? Can we automate that a little bit more? Can we make the quick action just a little bit faster? Can we improve the teamwork just a little bit, and every day just be better than the day before?
Can I ask how you think about measuring success for a lot of the initiatives that you're doing? Like, for example, maybe at a very high level, you're hoping that these efforts could impact, retention of clinicians and other kind of organizational goals. But how do you figure out, like, if you're moving the dial on the things that matter from a health IT point of view?
Yeah, it's kind of ironic that here we are in informatics where we think that we're based on data and algorithm and so forth, and we have a very hard time measuring improvement because it's quite subjective, right? There are clinicians who, when you look at their user action log, their Epic signal data, we're on Epic, and we can see when people are working into the evening, right? The whole pajama time concept. And it turns out when you ask people, so we're trying to minimize your pajama time, and some clinicians will say, no, that's not a problem for me. As long as I get home for dinner and I can, and the kids have homework, I can work from 8 to 10. That's not a problem for me. I actually prefer that rather than staying at work and trying to get it all done and then missing dinner because I'm done at 7, right? And pajama time in some metrics, starts counting at 7 o'clock and 7 p.m. and after. Well, gee, you measure me as having no pajama time. I'm totally burned out because I've missed dinner for the last, 6 months. On the other hand, there are clinicians where we see a lot of pajama time and they go, but I'm happy with it because, I get my time with my kids in the morning. I get my time with my kids at dinner time. And that's exactly what I'm looking for. So you can't take a pajama time metric and go, that's the end result. And, I know what's in your head because I know what time you're in the EHR. There's that. And then there's what clinicians perceive. We've actually used Net Promoter Score. And I hurt my elbow by patting myself on the back? We think we're one of the first to use Net Promoter Score from a different industry back in 2016. And that's been widely adopted now. And that's, I think, a slightly better measure of would you recommend the electronic health record as used in your practice to friends and colleagues. That's a slightly better measure than the action log. But then you have to go and do the survey and then figure out what to do with those results rather than having an automated capture of data. People want to do automated everything. Well, can't you just look at the signal data and figure out who's burned up? Well, yes, there's a hint there, but there's grunt work, there's footwork that you have to do to get around and figure out what's happening. This is hard work. I have to say it's not straightforward. Otherwise, we would have solved it already. Our big push is sprint teams, and we can talk about in-basket redesign as well. But these are sort of the large initiatives that we're trying to push forward incrementally.
It would be awesome if someone started benchmarking Net Promoter Score for how their EHR is used and learning from who's scoring better. That would be really fascinating.
I think, though, Stanford is starting to do this. I know that there's a collaborative of organizations doing wellness surveys, wellness/burnout surveys of clinicians, and we participate with that with about 6 other organizations. And we have started to do benchmarking of how satisfied are you with the efficiency of and the effectiveness of your EHR. And this first cycle, again, don't hurt your elbow, CT. We benchmarked relatively well against a couple of other organizations, but there's tons of work for all of us to do.
Well, I mean, just knowing him stage 7, Chimes Most Wired, level 10, like that speaks to it's kind of you've reached the peak, but it's inspirational knowing you're still looking to improve. It's always this iterative process. I do want to talk to you a little bit about in-basket redesign and documentation redesign. You've been an advocate for the APSO method over the SOAP method of documentation for a very long time. And I think you even made it mandatory when you implemented the latest instance of Epic. What was the reasoning for the documentation change? And then what made it so challenging to adopt?
Thank you for reading my blog. I think my readership is probably you and then my mother. But the APSO change is both. What's the big deal? I gave a talk on APSO note invention because of some innovation conference we had in Denver, and I gave this to a lay audience. And at the end, The audience reaction was, what's the big deal? You just moved some sections around in your note and that's innovation? What? And you talk to doctors like, you can't do that. That can't be allowed, can it? You want me to think backwards? I can't think backwards. And so it's both like heretical and also not an invention at all. So at the same time, we were looking at the transition from paper records to electronic records back in 1997 when we were first starting to do this to 2001. And one of my thoughts was, it is so hard to click open a patient's chart and then to scroll. And it's not the last page of the progress note you want, because that's all signatures and time and date stamps. It's like page 13 out of 15 where the assessment and plan is. And you just can't do that efficiently. You'll look up one or two notes, notwithstanding the fact that every note is available to you. You get tired after 2 or 3 notes because you just can't find the assessment and plan. All right, but the statement back then was, everyone knows when EHR comes to town, you can't find anything. Oh, well, I think I can fix that by inverting the assessment and plan and putting it at the top of the progress note. For which about half of my colleagues said, hey, that's a good idea. I like that. And the other half are like, you want me to write my plan and then go interview the patient? That doesn't make any sense. And you have to explain, no, the way you write, you can start halfway down the note with your subjective and then work your way back up to the top and finish at the top. How would that be? Oh, I couldn't possibly think that way. Oh, this is, you're just making more work for me just because you can, right? CT's moving stuff around just because he can. That's why he does things. This latest Epic upgrade, that thing that you wrote, that Epic thing, I'm like, yeah, that 20 million lines of codes that I wrote last weekend. But people have trouble with us moving their cheese because that's not the way I was trained. And when I put this out for trying to get people to adopt it, voluntarily, about 15% of my colleagues would. Hey, we created an APSO format and a SOAP format. Choose which template you want to use. And among my friends, I was able to strong arm about 15% of them to use it consistently. 85% were like, you know what? I looked at it. It's too hard to think about. And then just like with leading change, right? What's your burning platform? My burning platform was switching to Epic. And I told the white lie, oh, Epic only comes with APSO notes. So when you go to a new platform, that's all you'll have. And as a result, only the people who were most dedicated to fighting this stomped their feet and complained and went to the CEO. We allowed them an escape to go back and write SOAP notes. We built one just for their practice. And so right now, I think we're running about 88 to 90% APSO notes in our organization, 100% in primary care, and only among a handful of specialists do we have them writing regular SOAP notes. So sometimes having a burning platform can move the needle quite a bit.
Yeah, that's some significant progress. So I think back in the day, your very first study of it was like such a low adoption rate. And
I think the best thing is that like examples like this show that most people don't really care and will just go with whatever like the new paradigm is.
But you also have to give the why, right? Simon Sinek talks about start with why. And so often we don't do that. When I watched his TED Talk on start with why, I'm like, well, I do why all the time. And then I realized my why is at the bottom of a 3-page, 5-page, 7-page white paper. And you need to start with why. And so I've revamped the way I write my white papers now. When we're proposing a big change, I start with paragraph 1, executive summary. This is why this is important and we must do it now. And then we start with, and then go from there. It turns out the nurses adapted SOAP notes into SBAR. And I find that a very helpful way of formatting my white papers now is through the SBAR format. Situation, background, assessment, recommendations. So starting with the SOAP idea, and I've taken situation and transformed that into executive summary. Executive summary is, if you read nothing else, this is why we're doing what we're doing. Now, if you're interested, I'll tell you the how and the what. I find that to be much more effective than the way I used to write it, which was people get tired of reading your stuff. They never get to the last page, and you got to start with why.
I love that because sometimes people only care about the executive summary. Otherwise, they're not going to read it at all.
Right. So,
now, CT, in the first year of the pandemic, you actually put together, I believe it was called My Failure Resumé, and it was chronicling some of your greatest learning lessons throughout your career. I absolutely love the resume. It really seems like you've just had a tremendous amount of resilience and grit throughout your whole career. And I think you even stated on the resume, you just have to get up one more time, then you fall down. And I love that. I'm really curious, how have you embraced failure to find success that you've had? What were maybe one or two of the the most profound failures you've had?
My favorite example was the radiology indications of use. This was something that we were trying 2006, 2007, and we thought, well, gee, actually it was a little bit later, 2011 or so. But the idea was that we were hearing inklings that we would not have to go to the insurance company for pre-authorization if we could send ahead of time a selected indication of use for a CT scan or an MRI. And if we could suggest to the clinician, hey, you're about to do a head CT. If this is for risk of acute bleeding from trauma, then it sails right through the authorization process. Why don't we put a checkbox for acute trauma, head bleed suspected, right in front of the clinician? And we're patting ourselves. So that was a great idea. Wow, this is going to be fantastic. And for head CT, turns out there are about 80 indications. Well, there's 80 indications. Why don't we just alphabetize them? Yeah, that'll do it. And so what we didn't realize, of course, is that 80 indications, even in 2 columns, will scroll off the screen to 2 and 3 screens. And so clinicians going, oh, I don't know. Do I look under T for trauma or A for acute or B for bleeding? I can't find it. And so after trying for a few, we turned this on, we stood back and we were like, this is going to be amazing. Everything's going to sail through. And there was immediately an outbreak of acromegaly in our organization. Because
first one.
Acromegaly, option number 1, hey, we know that sails through. Just click the first one on the screen. And so, wow, that's completely unintended consequence of a technological change. And so after 2 days, we had to take it out because no one was putting in accurate findings. You can't find it. Now, we've been finally successful in the past couple of years. That's taken a decade to get to this. But now we have sort of an AI behind the scenes that reads the phrase that the clinician types in. I'm worried about an acute bleed from a trauma from an MVA such and such. And then it takes that and says, I think you meant trauma, acute bleed suspected. Yes, right? And so that's, we've been able to get our indications of use finally redeployed, 10 years later with a second tool, but to try to simplify it for the frontline clinician and doing a lot more user testing than we did in the beginning. So yes, flamed out in a big way and try a different approach, CT.
It sounds like one of the key themes is how do you reduce friction to people doing, let's call it the right thing or the intended thing, right? There's all very smart people, but they're so busy, they're strapped for time. If it's not easy to do the right thing.
And even as an informaticist, right? So the first step is to go from having an analyst design it who has no clinical background and then just deploying the tool to having an analyst talk with a clinician and try to design it for that clinician. That's slightly better. And then beyond that is having a clinician who's an informaticist who has a foot in both worlds who can say, yes, I know what the tools can do. Yes, I'm a practicing clinician. I can build something that, neither of these individual partners might be able to do. And then sort of trying to iterate on top of that. And so we find that we're slightly better than we used to be. We still have a long way to go.
Yeah, I like that. So CT, today there is this explosion of patient-facing innovations. There's everything from chatbots and digital care journeys, remote patient monitoring. I'm curious, what are you most excited about today?
Well, this is a recent thing, but ChatGPT-3 is kind of blowing up right now. Clinicians are figuring out, and not just clinicians, but everyone's figuring out, asking it questions, and it having terabytes of the internet to have read and be able to respond to you in an innovative way. I think there's some really exciting ideas that if ChatGPT-3 or its next cousin, GPT-4, whatever's coming, if we allowed it to read, for example, our EHR corpus within our organization, and then to say, I think I understand how most of your clinicians will respond to patient questions. I could imagine the in-basket tasks being dramatically simpler if it would respond for you and then you would read it and go, yeah, I think I would say that.
Right.
And hit send. That could be dramatically better. Patients would get good advice. It's in the voice of the clinician because these are the things I've said to thousands of other patients before, and they could package it up for me. I don't think it's quite ready for prime time in that you can't just hit the button and fire and forget and hope that it says the right thing. One of my colleagues did actually ask it to write a proposal based on, AMIA literature, and it came back with this beautiful proposal. But if you go and look at the references, they're all manufactured references. They aren't real. And
Oh, wow.
They look like real references because ChatGPT knows how to format them in such a way that you're like, that's a beautiful recipe. I didn't know someone wrote something like that. It doesn't exist, right?
Wow.
So be careful for what you ask for, because it doesn't understand the difference between fluency, which is like it reads great, and truth or accuracy or intent. And so I think there's some big gaps that we have to be careful about. One of the things I think about is AI. It's not really a matter of AI versus clinician. It's an AI augmented clinician. They can be better than a clinician by themselves. That's true for the EHR in general if we do the right thing. But I think the introduction of AI tools, it's big risk and big opportunity at the same time. We have to be careful about it.
I love that. Some of these questions on this podcast today may or may not have been written in part by ChatGPT. And I really appreciate that input.
You know, one day someone's going to go to ChatGPT and type something like, write a parody in the style of a CT Lin song.
But there is so much like personal nuance that, you know, CT you bring into your parody. So I don't think at least at this point AI could replicate anything close to the art that you make.
Yeah.
But
I will say that one thing I saw on Twitter the other day was a clinician who said, please write the difference between hospice and palliative care in the style of Dr. Seuss. And you read it, and the palliative care doc says, I wish my colleagues understood the nuances between hospice and palliative care as much as ChatGPT does in this Dr. Seuss rhyme. Like, wow, that's amazing. So there are some amazing things that, you know, some little gems that will even now come out that you're like, there's some interesting potential here.
Totally.
I think I'm excited for, like, if they can get the clinical side correct and safe for patients, be able to translate stuff into various like health literacy levels for patients.
Right.
That would be really neat.
Yeah. Well, CT, just be mindful of your time. Let's flip over to what we call the Fast 5 lightning round. 5 quick questions to get to know you better. The first question we have, what is your favorite book or book you've gifted the most?
Ender's Game.
Oh, nice. I love that. Question 2, who is a person, either dead or alive, you'd love to meet?
I don't really have a good name for you. I'll pass.
Okay. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I'm going to say, was it Superman super speed, so that I could, speed up time? I'd love to see 20 years into the future, you know, what we're doing at that point, and then bring that back and go, why can't we do that now?
Yeah.
Right? So that would be my idea.
I love it. Question 4, what is something in healthcare you believe that others might find insane?
You know, when I served on the board of directors, we had a number of non-healthcare executives sit on our board, and they would just sit there and go, why can't you set your own prices? And how come you have to listen to the government on such and such? The fact that patients, payers, pharmacy benefit managers, providers, health systems, our motivations are not all aligned. And the person who pays for it doesn't receive the service. And it's just arcane, the environment that we have to live in.
Great point. Last question that we have, if you could travel back in time to any event or moment, what would it be and why?
You know, what fascinates me is cultural change. The things that are the most interesting and fascinating in my world in informatics is switching cultures, going toward a culture of transparency from a culture of paternalism, using electronic health records and accepting them as partners in our delivery of care. And my son is reading the great books right now, and the switch from Ptolemy to Copernicus, the geocentric view to the heliocentric view, and how that must have blown people's minds back then. I would have loved to be part of that conversation.
Yeah, that would have been wild. Well, awesome. CT, thank you so much for taking the time to come on the show today. You can find CT on Twitter at CTLin1 and through his blog, The Undiscovered Country, at ctlin.blog. I think The Undiscovered Country, is that a Hamlet reference? I'm just piecing this together now.
Yes,
okay. That's awesome. Well, that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and you want to learn more, you can visit www.seamless.md. CT Lin, it's been an absolute pleasure having you on the show today.
Thanks, CT.
Thank you.